It's working? All good? All right. Okay, hi everyone. Let's start, I guess. Sorry for the delay. So today we're going through the two GP topics of ear, nose, and throat and ophthalm. They're huge topics. I don't know. The powers that be decided that they should be presented together. So let's give it a go in 2 hours and we'll see how far we get. So, nope, not on this one. Just quickly, in terms of ENT, this is what we're going to cover. We're going to cover a bit of ear anatomy because that's maybe will come back on your VIA. The other anatomies probably won't, but hey, nothing's impossible. Then we'll go through the painful ear, the full ear, hearing loss, vertigo, a bit of nose, a bit of throat, and clinical. Probably 80% of ENT is ear for GP. So there's that. And then just a little bit of a chat about exams. They're sort of soon-ish. This is very real. You'll feel it. Sort of one piece of information will come in and another one will fall out because you just have a certain hard disk space. It's fine. You'll be okay. Just revise. Things I'd recommend are past medicine. It's like a good question bank and it's not particularly expensive. BMJ is more expensive and it's also very demoralizing. So unless you want them like, that last 5%, 10%, 15% of marks, past med is fine, and it's also at a good standard of Monash, and it's sort of written in a similar way. And otherwise, I'm sure as everyone's telling you, if you're not practicing OSCEs, please start now because they sneak up on you, and there's just a lot to learn. Someone last year told me that the OSCEs are great because they only are on the 4th year topics. And I was like, oh, that's amazing. I only need to know 3 areas, and then I realized the GP is everything. So, there's a lot to cover, but you'll be okay. So the key is just to slowly just churn away at it, keep looking at stuff over and over and over again, and it'll all stick eventually, hopefully, and then just forget all about it afterwards. Okay, so let's start with some ENT. This will also be you. Okay, so in terms of ear, these are variably ears with gauges or onion rings or calamari. So this is some anatomy of the ear. So you've got your outer ear, middle ear, and inner ear. It's not too complicated. The outer ear has a pinna or an auricle. You've got an ear canal connected to the eardrum. So essentially sound comes in. So the outer ear acts as a satellite dish for sound waves. They're converted into mechanical energy, which is transmitted across the malleus incus and stapes. And then those are transmitted into the fluid-filled cavity of the cochlea, which is then transferred into electrical energy into your brain, and that's how you hear. Just a touch of revision. This is the, so this is the Eustachian tube, and it connects to the sort of back of your nose. And so you'll find out why that's quite important soon. So this is the outer ear. I won't sort of bore you with the details, but if you want to learn this for your VIA, you can. This is the eardrum. For bonus points, can anyone tell me which ear this is? Which? Right. Yeah, good. Yes. That's probably on me. Okay, so the things that are probably important to know. Everyone always likes to tell me about the cone of light, which I think is kind of funny because the cone of light isn't really an anatomical structure. It only exists when you point your torch down the ear. So things that are important are the pars tensor and then flaccida, because that'll distinguish different ear tympanic membrane perforations. And then this is basically your malleus. And those are the landmarks. And the way that you tell if it's a right or a left ear is that the malleus should be pointing towards the nose, if that makes sense. So it's sort of pointing towards the nose. If you were looking at someone's right ear, their malleus would be this way. So the middle ear, I'm sure you all have fond memories of this picture. It is important though, perhaps for the VIA, less so for your GP exams. And the main things that you should know about are basically where the facial nerve is, where the Eustachian tube is, and who can tell me which, so the oval window or the round window, which of these the foot plate of the stapes attaches to. Is anyone there? I'm going to run out of photos, but that's okay. Oval around, 50-50. Yeah, good. So the foot plate of the, this is going to be bad. That'll do. So the footplate of the stapes is oval. If you'll remember, it's sort of got these two prongs, and it like attaches to like a surfboard shape. So that sits over the oval window, and the round window is to allow for vibrations sort of to exit the ear, vaguely. Okay, this is the inner ear. You don't really need to know about it, except to know that this is the balance organ and this is the hearing organ. And the balance organ has little rocks in it, vaguely. And they help you basically orient yourself in space, and this has your hearing. Okay, so the painful ear. I love this picture because that kid is adorable and funny. The stuff in red is stuff that I think could come up on an OSCE. And the stuff that is tiny, you probably need to know one line about. And the stuff that's neither is worthwhile knowing about, but is unlikely to be sort of OSCE'd. That being said, disclaimer, anything can happen. You might have a full station on barotrauma. Who knows? So in terms of a painful ear, it's all external ear and middle ear. My formatting's gone a bit off. So otitis externa, acute otitis media, chronic suppurative otitis media, and chronic otitis media with effusion or otitis media with effusion are probably the four big ones for painful ear. So let's start. In the top right-hand corner, just in case you fall asleep at some point during this lecture, which is liable, there's a little guide of where we are anatomically. So just in case you get lost. So otitis externa, the big risk factor is swimmers. That'll be your buzzword in your question. Typically someone will be in Bali and they'll like go swimming in some random pool and then they'll get otitis externa. And it's basically just inflammation and infection of the external auditory canal. People who also get are cotton bud abusers. Put your hand up if you use cotton buds. Stop it. Cool. So your ears clean themselves. They're very clever. In any case, so the causes can either be bacterial, fungal, or dermatological. Bacterial causes are pretty straightforward, except that Pseudomonas can give you a nasty infection called malignant otitis externa, which can give you a skull-based infection, and the fungal ones can also be a bit nasty, such as Aspergillus and Candida. Does anyone know what this one is? The one in the bottom? Aspergillus. Yeah, good. So Aspergillus niger. I think auricle is just people's catching, to be perfectly honest. So you can tell that by the little black spore things. So it's like ear mushrooms. Okay, so the symptoms of otitis externa, the main thing is that it's itchy and painful. So with all the other painful ears, middle ear conditions, they won't be so painful to touch. So this will be like a really red hot, angry, inflamed outer ear. There might be some discharge or sort of debris, and signs will be an edematous canal, and you might have erythema, some discharge, and tenderness to touch or TMJ movement, so chewing. And it can be focal or diffuse. So the treatment is essentially symptomatic, and then you can do some dry oral toileting. So the main thing with these people is to keep their ears really dry until the infection resolves, because all of these bugs love moisture, and so if you keep them dry, that's a good environment to kill them. And then the rest is just drops. So ENTs, particularly particularly otologists or people who deal with ear infections generally, love drops. There are all sorts. But the main ones you should probably know, just off the top of your head, maybe know, if you have to remember one, probably Kenacomb, because you can sort of use it for both, but no Suppurative, and then Kenacomb is specifically for fungal. And then if you have a localized infection, you can give some oral flu clots. Okay, so here are just a couple of bits and pieces. There's pharyngitis, which is a staph infection of a hair follicle. The treatment is drainage. And then there's exostosis, which is surface ears. So the reason why that happens is the cold water going into the ear over and over again results in some bony formation, and you get these sort of little bony outgrowths in the ear canal. It's not too painful, generally asymptomatic, but it can result in a conductive hearing loss. And the treatment is surgery and keeping the ear dry when you surf or swim. Okay, so here are some other bits and pieces. So Ramsay-Hunt syndrome is herpes zoster virus, including the geniculate ganglion, and that can lead to herpes zoster oticus, which is herpes of the outer ear, plus minus a facial nerve palsy. So Ramsay-Hunt syndrome is really the whole shebang. It's not just the herpes of the outer ear. Okay, so this, if I had to pick like one ENT condition that might come up, it'd either be this or tonsillitis, maybe, as an OSCE, where they could really get into it. We didn't have any last year, so maybe it'll come up. So it's basically infection of the middle ear, rather. The pathophys is basically stasis is the basis of infection. You generally get nasopharyngeal blockage that stops the eustachian tube from draining. So this will be like an upper respiratory tract infection. You'll have sort of mucus and all sorts of gunk in the nose, and that'll block the openings of the eustachian tubes, and then those viruses or bacteria or whatever can sort of climb up. And those are the main bugs. The people who get it the most are young children. Does anyone know why? Yeah, good. So the eustachian tubes are flatter and more malleable. That was my bad, sorry. There's just going to be Freddo frogs strewn across this lecture theatre. Anyway, do you want another one? Okay. So the symptoms. So pain. So children, particularly if they can't verbalize that they're feeling pain, they'll pull at their ears a lot. Thus that picture earlier, somewhere. Where is it? This one. Yes, they'll be pulling at the ears, and otherwise a feeling of fullness in the ear as well as fever plus minus vomiting. In children, fever can present in any way, shape or form. They might have abdominal pain, and the main thing might be acute otitis media. So you'll see in pediatrics that the doctors will always check the ears, and they'll do a general head to toe. So the signs are generally just systemic illness, and on tympanometry, you might see the following. So early, you'll get a hypervascular tympanic membrane, and it spreads superior to inferior. And then later, you'll get purulent discharge behind the tympanic membrane, and loss of the light reflex because of bulging of the eardrum, as well as swelling. So these are some pictures of acute otitis media. So this is early, this is with pus, and then when it's too late, it's perforation. Does anyone know what this is? So it's a Guylian shrimp chocolate, but I think it looks a little bit like this. Anyway, that's just how I remember it, not that it needs remembering. So the treatment is self-limiting. Essentially, you just need to give some TLC, paracetamol, ibuprofen, decongestant, maybe just to sort of let the eustachian tubes drain. And you don't give antibiotics unless they are one of these things. So I've put them in bold. The main ones are probably less than 6 months, so really little kids and active populations, as well as if they've haven't had it for more than 48 hours. And you give amoxi for 5 to 7 days, 5 days TDS. Okay, the prognosis is that it's usually a self-limiting disease. If perforation occurs, it will likely resolve itself because sort of once you've perforated, then you allow for drainage of whatever infection is in the middle ear. But it may progress to otitis media with effusion or chronic suppurative otitis media. So, and particularly chronic suppurative otitis media. So, recurrent bacterial otitis media risk factors are smoking exposure. So if there are parents smoking at home, or if the child is smoking, group childcare, allergic rhinitis, eustachian tube dysfunction for obvious reasons. Essentially, these ones are stuff that blocks up the nose. So chronic suppurative otitis media is a bit of a different beast. So this necessarily, it has to have a perforation, which is an important point, and it has to last for more than 6 weeks. So that's what CSOM is. Does anyone know the difference between a safe and unsafe perforation? You nodded?
Yeah, it depends on the location of the perforation.
Good. So where's a safe perforation?
It's the lower area of the attic.
Sorry?
The attic.
Is unsafe? Good. Yes. I feel like people are going to stop answering questions for fear of my chocolate drawing skills, but yeah, that's right. You can tell that I didn't play sport in school. So yeah, so safe perforation is in the pars tensor. So this is just a reminder diagram. So the pars tensor is here, and it doesn't involve the border, and the discharge is inoffensive. An unsafe perforation is in the attic with foul purulent discharge, and the reason why this is unsafe is because it can lead to a cholesteatoma. So what's cholesteatoma? I think we cover it later. So the symptoms of CSOM are deafness and painless discharge. So people will just wake up in the morning with some discolored discharge on their pillow, and they'll go on with life being a little bit deaf. The complications are that you can have intracranial disease, mastoiditis, and cholesteatoma. So mastoiditis is an infection of the mastoid. So the mastoid is this sort of bony prominence behind the ear. It's full of air. It's kind of like a honeycomb, and whatever, we won't get into the function, but it can fill with pus as well. And a cholesteatoma is basically a little tiny non-malignant tumor type thing. It's basically like a little ball of keratin, and it just grows and grows and grows. In the same way that the eardrum replenishes itself, it's sort of like a little bleb of eardrum that just replenishes itself and just gets bigger, 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 and can cause some damage. So the treatment for CSOM is that first you have to clean the ear very carefully with microsuction and mopping. So again, keeping the ear quite dry, and then Ciproxin HC ear drops, BD, until free of discharge for 3 days. Cool. Okay, so also tell me if I'm going too fast. Yeah. I'll try to listen, but we have a lot to get through. So otitis media with effusion is presence of middle ear fluid without signs of illness or inflammation. So this is now non-infective fluid. And it's typically post-acute otitis media, but it can be induced by barotrauma or allergy. So eustachian tube dysfunction is a predisposing factor, and it typically lasts for 4 months, but it can be longer. So the reason why eustachian tube dysfunction is a predisposing factor is because essentially fluid has to get into the ear somehow, and either it happens post-infection where the sort of lining of the eardrum of the middle ear is angry and it's sort of there's an exudate, or it's because of a buildup of negative pressure and you sort of get a transudated fluid into the middle ear. So yeah, that's that. The symptoms are long-term conductive hearing loss, but it sort of comes and goes because sometimes, oh, sorry, no, I'm talking about eustachian tube dysfunction. No, this is long-term conductive hearing loss, and the signs are clear blue-gray fluid behind the tympanic membrane, plus minus bubbles if there's sort of air, and then when it fills more than the bubbles disappear, as well as eardrum retraction. So because you've got that negative pressure, it sort of pulls back on the eardrum, because the eardrum is like a piece of cling film. Treatment is basically audiology for baseline, so you can see how they're tracking, and then follow up for resolution. So when do you put grommets in? Does anyone know? There's a lot. I'll just tell you. So indications for grommets are recurrent bacterial otitis media. So if a kid's getting otitis media like 6 times a year, it's probably time to do something about it. Persistent glue ear for more than 10 weeks with bilateral conductive hearing loss over 30 decibels and flat type B tympanograms. Do you have to remember that all? No, but I would know just like persistent glue ear in both ears, or on one side for more than 6 months. So essentially the reason why you worry about this is because if they've got reduced hearing, particularly in children, you can have developmental delay. So it might not seem like a big deal that they can't hear that well, but if they're in class and they're not, they can't hear their teacher and stuff, they can sort of fall behind quite badly. So at-risk populations are ATSI populations, people who already have some degree of developmental delay, as well as people with Down's syndrome, cleft lip, structural abnormalities, etc. Okay, so that's painful ear, done. Well, that's all the stuff you need to know about painful ear. Now let's talk about full ear. So these can also give you symptoms of full ear, but we've already talked about them. So what we're going to talk today about is mainly eustachian tube dysfunction, and then Meniere's will come later. Meniere's is also quite important to know about, just because would happen. It would be mean, but it could. So yeah, I would know a little bit about that. So eustachian tube dysfunction, just a quick word on wax impaction. It's mainly cotton bud abusers and people, yeah, they just sort of impact the wax into their ears and then they get stuck and it can cause conductive hearing loss. That's essentially all you need to know. You can give them olive oil drops to soften it. Yeah. So eustachian tube dysfunction. It's chronic issues with maintaining patency of the eustachian tube and subsequently ventilation of the middle ear. So essentially the eustachian tube blocks off periodically, and then you end up with negative pressures in the ears. So the risk factors are children, for the reasons we mentioned, middle-aged females, having an upper respiratory tract infection, as well as flying, because again, the negative pressures. I'm sure we've all had blocked ears on a plane. The symptoms are a periodical feeling of oral fullness, and that comes and goes. So you sort of suddenly have full ear, and then like maybe a couple of hours later, it's fine, and then it comes back a few days later. It's very irritating, and your hearing goes, and it leads to a conductive hearing defect. So you might hear clicking when swallowing, because when you swallow, you sort of tug on the eustachian tubes, and it's not painful, and there's no systemic symptoms. So if someone just comes in with sort of periodic conductive hearing loss or just hearing loss, that's something to keep in mind. And the signs are a type C tympanogram, which I will talk about shortly. And you might see a retracted tympanic membrane with no fluid. So it's sort of just like glad wrap being sucked back onto the tympanic membrane. Okay, so the treatment is that 30% will resolve spontaneously, and basically you can just teach people to Valsalva to try and open up their eustachian tubes, and you can give them this combo, which is like a favorite of ENTs. It's just like saline, so saline, steroid, plus minus some sort of nasal moisturizer, because steroids can dry out the nose, and antihistamines to keep the nose clear. So this is for like allergic rhinitis, eustachian tube dysfunction, anything where you want like the nose to calm down. And then if it's intractable, you can put in grommets. Okay, that's a full ear done. And now let's move on to hearing loss. So again, all of these things can cause some degree of hearing loss, but what we haven't covered are these. So let's go through that. So this is, does anyone know how tympanometry is done? Or what it is, vaguely? There's no chocolate for this one. Okay, so basically they put in a probe and they shoot air at the eardrum and they see how it moves. So it's basically just telling you the stiffness or the looseness of the eardrum at different pressures. And so A is normal, and then B and C are the only two others that I know, where B is the downsloping one, and it basically means that the eardrum is not moving, so like a infection or glue ear, and then C means that there's negative pressure, so eustachian tube dysfunction. So audiometry, this could come up on your exam, maybe if they were feeling really mean, but they'd give you a key. But the key to know is that there's air conduction and bone conduction. I remember brackets are bone. So can anyone tell me if you wanted to measure conductive hearing or sensorineural hearing loss, which of the two tells you more about sensorineural hearing loss? Can I pick on someone, or is that mean? Ryan? Do you know?
No, I'm trying to.
All right.
On the question.
Yeah. Oh, the question was, so is air conduction or bone conduction tell you more about sensorineural hearing, so cochlear hearing?
Bone conduction.
Bone conduction. Good. So why? I'll probably just come give it to you. So why bone conduction?
Well, air conduction makes sense with conductive hearing loss because of the blockage. So yeah, just going the opposite of that. Yeah.
Okay. So air conduction is basically telling you how sound travels normally. So all the way from the outside to the inside. So it has to go through the outer ear, the middle ear, and the inner ear to produce a sound. Bone conduction, on the other hand, although it somewhat is transmitted through the middle ear, it essentially bypasses the outer and middle ear and goes straight into the cochlea. So that really tells you about sensorineural hearing, whereas air conduction sort of tells you about the whole hearing organ. And so by comparing the two, you can sort of piece together which one it is. So these are the ranges, you don't need to know them. But there are some patterns that you should know. So normally air conduction and bone conduction should be the same. In conductive hearing loss, all frequencies are affected with air conduction worse than bone conduction, which makes sense, right? Because with bone conduction, you're bypassing middle ear. So you're basically bypassing the problem. Whereas in sensorineural hearing, air conduction and bone conduction are similar but both affected. So for example, in otosclerosis, which is a congenital condition where the ossicles of the middle ear sort of fuse or become hardened, you get this particular audiometry pattern where you get progressive conductive hearing loss, beginning in low frequencies, but basically affecting all of them. And then a specific 2000 hertz notch in sensorineural hearing, which is odd. So in bone conduction, right? So I'll show you that. And it's caused by sclerosis of the stapedal foot plate, and it generally develops in 20 to 30-year-olds. It's autosomal dominant and usually in females. So you refer them for a stapedectomy. So this is their audiogram. So you can see this is bone conduction and this is air conduction. So this is essentially sensorineural and this is conductive. So conductive is all affected and sensorineural is all pretty okay, but there's this notch at 2000. So that's your Carhart's notch. Okay, so these are some more patterns. Does anyone know what this one is? It's on the slide, so no points. Yeah, so this is presbyocusis. So just age-related hearing loss. So you get hearing loss in the high frequencies. And the reason why that is because the cochlea is like, it's a spiral, it's like a snail shell. But if you rolled it out, it would be a long tube. And all the sound has to travel up the cochlea. And the hair cells at the very front of the cochlea are the high frequency ones. So they, regardless of whether it's low frequency, high frequency, whatever, they're getting the vibrations, whereas the ones at the end only really get the low frequency ones. So that's why they're exposed to more noise and they get damaged more over a person's lifetime. And this will present in a question, they'll be like, has trouble hearing people in crowds, that kind of thing. Whereas this is noise-induced hearing loss. So this is someone's air conductive hearing loss. And you can see that there's a notch at a specific frequency. So that's, so for instance, gunshot. Say someone's a hunter. That's the audiogram that they would have. Then acoustic neuroma is sort of bilateral, slow onset sensorineural hearing loss. It can be unilateral though. Anytime that there's unilateral sensorineural hearing loss, you should refer them for an MRI or to an ENT. Yeah, because the chances are there's something. It's unlikely to be anything, but it could be something. So let's talk about vertigo. So vertigo is the illusion of movement. So either of your body or your environment is moving, and you have to distinguish it from lightheadedness and fainting episodes or unsteadiness on the feet, because people will come in and they'll say, you know, I'm dizzy, but they might just mean that they, you know, when they get up, they feel dizzy, as opposed to true vertigo where the room is spinning. Okay, so let's go through vertigo. This is the best way to learn it because there's like 5 conditions. 1, 2, 3, 4. Yep. And yeah, you can learn it in this framework. So let's just go around the room. No prizes, sorry. And name them one by one. All right, so BPPV, what's the time course? Or who hasn't done GP? Okay, that's good. I'll just skip you. Or you can try, give it a go.
There you go.
Yep.
30 to 40 seconds.
Very specific. But yeah, brief. So a period of seconds, right? Maybe under a couple of minutes. Yeah, what about clinical features of BPPV?
So when someone moves their head into a different position, they get a sensation of vertigo. So like when they're looking up to a shelf or when they're rolling over their head.
Yeah, exactly. So postural vertigo and head change. So the classic question will be, you know, when they look up to get dishes out of the top drawer or when they roll over in bed. Renee, what are the diagnostic tests for BPPV? Yes. Good. So the Dix-Hall-Pike maneuver, which looks like this. It's very scary. You have to tell your patients you're doing it before you do it, because they might think you're like trying to snap their neck or something. So you basically just take the head and you bring them down and then turn the head at the same time. And that's meant to get the otoliths to sort of spin around their canals and sort of get them going. And you'll see sort of nystagmus when you do that. Okay. So following on from that, do you happen to know the treatment for BPPV? That's, yep, part of it.
Repositioning.
Yes, and what else does it say? All right, Jason, do you know?
You should read my notes.
Does anyone know? It's like a Dix-Hall-Pike, but more complicated.
Yes.
Epley's, good. So the Epley maneuver. So yes, you can give antiemetics, you can reposition them, but the thing to teach patients is an Epley's maneuver, which is, I think, really clever medicine. So basically someone realized that the reason why this happens is because of the otoliths in the canal. So essentially what you're just trying to do is move these otoliths from one position into another position. So you start off with the normal Dix-Hall-Pike, then you roll them over, do another head thing, and then another. Basically you teach them how to do this maneuver, and that then allows them to self-manage their condition. Cool, okay, vestibular neuronitis. Do you know? Time course?
Minutes to hours?
Yeah, even days, right? So this of all of them, I'd probably say this one's the worst, except for maybe lateral medullary syndrome, because that means you've had a stroke. But this one symptomatically sounds really bad. So basically, you have vertigo for days. I don't know how I'd stand that. And then, do you know what the clinical features are? Okay, so essentially, you might have a choroidal prodrome because it's one of those things where they think it's related to a virus. But essentially, you just have vertigo with no loss of hearing. But if you do have loss of hearing, then it's a labyrinthitis. So vestibular neuronitis is just the vestibular neurons, and a labyrinthitis is of the whole labyrinth, right, of the whole sort of cranial nerve. Okay, anyone know the diagnostic tests? None? Do you know the diagnostic tests for EN? No. Okay, so essentially you do head thrust. So the head thrust test looks like this, and you again looking for nystagmus. So you just take the head and you just go, give it a good yank, and you should see nystagmus in the other direction. Anyone know the management? Okay, so I'll put it to you this way. How do you treat a Bell's palsy or any of these like post-viral nerve damages? I think someone said the first letter, maybe. Steroids, yeah. You just pump them full of some steroids. So you give them corticosteroids and antiemetics because they're going to be feeling really sick. But all those, like Bell's palsy, sudden sensorineural hearing loss, VN, what's another one? Those are the ones I can think of now. You're just pumping full of steroids, basically, because you're trying to reduce the inflammation on the nerve, which is theorized that's how it works. Okay, so what's the time course of Meniere's? Sorry, I don't know anyone's name. Minutes? Yeah, good. So it's sort of episodes of minutes. And okay, moving on to you at the end. Do you know what the clinical features are? It's triad.
Rhinitis, tinnitus,
Yes.
sensory loss,
Yes.
and vertigo.
Very good. Okay. So it's tinnitus, sensory neural hearing loss, and vertigo, and you can get these like drop attacks. The diagnostic tests for Meniere's, do you know, Zoha? So yeah, audiometry, right? And just do an audiogram and just see what else is going on. But otherwise, it's sort of hard to tell. Does anyone know why it happens, just briefly? So it's a high drops. It's an overaccumulation of fluid in the canals, and so it's sort of hard to image, to sort of test for that, although I think it is possible. All right, so what's the management of Meniere's? All the time? Mm-hmm. Anything else? There's a drug you can give, preventative? Yes, good. Okay, so low salt diet, low fluid. You essentially want to get fluid out of there, out of the sensory organ. So low salt diet, low fluid, and then you can give chlorpromazine or Stemtil. I think beta histine is hiding under that block, but we'll find out. But yes, beta histine is right. Okay, so what about the time course of a vestibular migraine? Yeah, sure. Just like any migraine, it sort of lasts minutes to hours. Do you know what the clinical features of a vestibular migraine are? The answer at the top of the page. Vertigo, good. But there's no hearing loss, which is the main thing, and you might get some tinnitus. But it's sort of tricky to pick because you might not have a headache with it. So you sort of have these symptoms, and they kind of come out of nowhere. Anyone know what the diagnostic test is for vestibular migraine, Ryan? So there aren't any. Good. And then do you know what the management is? How do you manage a migraine? Just general migraine management, yeah? That's what I've written. So that's good enough, migraine management. But essentially, put them in a dark room, make sure they're not like rolling around and going on roller coasters and stuff, and give them the relevant medications. Cool, okay. Renee, do you know the time course of lateral medullary syndrome?
Like sudden onset?
Yeah, and then forever. Good. Okay, do you know the clinical features? Yes, good. This one's probably the trickiest. Okay, so let's go through it. Vertigo. So this is a stroke of the lateral medulla, and it gives you vertigo, ipsilateral cerebellar lesion, contralateral spinothalamic lesions in the body, ipsilateral face, sensory, and then dysphagia, hoarseness, and a Horner syndrome. It's like one of these syndromes that they like to test you on. Often in the neuro questions, when there was like a weird constellation of symptoms, I think I learned these ones, and then I would usually just answer lateral medullary syndrome. It's usually right for like the really weird locator lesions, but I'm not a neuro whiz. So, and then do you know the diagnostic test for lateral medullary syndrome?
Probably CT.
Yeah, good. Or an MRI. Yep. So either, but for a stroke, good. And then how do you manage it? Beautiful. Love it. Okay. Okay, so let's talk about, actually, no, let's skip this. If you want to know more about Meniere's disease, read these slides. One thing that I didn't mention is roaring tinnitus is the buzzword. I think you might have said that maybe. Yeah. And that's what you need to know. Okay. Okay. And then other things that can give you tinnitus are like vascular malformations and some drugs. But we won't go through that today. The main thing about tinnitus is that it has a huge psychiatric impact. So old people sometimes commit suicide because of it, especially if they're living alone. It sort of just drives you up the wall. The investigations are audiology, vestibular function testing, tympanometry and speech discrimination, and an MRI if you suspect a serious cause, or particularly if it's unilateral. And then the treatment is basically, there's not much to do, but you can sort of help them deal with it. So hearing tests, hearing aids, sound therapy, CBT, and drug therapy doesn't really work all that well. Okay, that's ear. That's probably most of ENT. What's the time? Oh yeah, okay. we'll try to keep it short. If you guys get too tired and want to go home, I fully understand. Okay, so let's talk about nose. So the blocked nose. The main thing you need to know here is allergic rhinitis and like rhinosinusitis, and the rest is basically a cold, polyps, and a broken nose. Yeah. And then the last one is decongestant dependence, and that's basically all you have to know about. Okay, so rhinosinusitis is infection of the nose and sinuses. The symptoms are one of discolored nasal discharge, so it's not just a clear runny nose like a cold, so you have to have some sort of discolored nasal discharge, and nasal obstruction with frontal pain, headache, or reduced smell. And the main thing that they'll give you in the question is like discolored nasal discharge, maybe some frontal pain and a headache, and that'll be your sinusitis question. Like in an MCQ. So it can be viral or bacterial, and the color of the discharge sort of tells you if it's bacterial or not, but not necessarily. So it really has to be quite discolored for you to be like, oh yeah, that looks quite bacterial. So yellow doesn't quite cut it. So you need more than 10 days of symptoms, double sickening, which means you sort of have the illness and you sort of get better, but then you get worse again. Discolored discharge, severe local pain, a high fever, and elevated CRP and ESR. But it's generally self-limiting. So you just basically manage it like a cold, right? So you give hydrate, inhale steam. Nasal saline douche can be helpful to irrigate the sinuses. And then you can give decongestants, but you don't give it for longer than 5 days, or else you can get rhinitis medicamentosa, which the long and the short of it is it's a decongestant and it's a vasoconstrictor, and your vessels get addicted to having it and keeping the nose clear. So when you take it away, then your nose just sort of fills up again, and people are like, oh, this is shit, so they start using it again, and they get addicted. So like there are people who like are spraying this stuff up their nose like for 2 years. Yeah, it's pretty awful. So 3 days is what it says on the label, and definitely not longer than 5 days. And if it's bacterial or chronic, you can give amoxicillin TDS for 7 to 10 days. So rhinitis generally is inflammation of the nasal mucosa, and it's mostly allergic. So it can either be seasonal, which is like your classic hay fever, or perennial, so things like dust mites or danders that are sort of there all the time. And the symptoms are hay fever symptoms. So a blocked nose, which leads to mouth breathing, rhinorrhea, sneezing, reduced sense of smell, itching nose, and it might be accompanied by itchy eyes and classic hay fever stuff. And the investigations are IgE antibodies, and then send them for allergy testing. And the treatment is basically remove the cause, and again, intranasal saline, nose oil, plus minus antihistamines, plus minus nose oil, sorry, Nasonex, gold. Great. So if you say that in your exam / OSCE, they'll be very happy. Okay, so just a couple of bits and bobs. Septal hematoma is a post-traumatic, you basically just get blood collecting around the septum, and it's visible on anterior rhinoscopy, i.e. when you look up someone's nose. It needs to be drained, otherwise it can sort of erode the septum and lead to a saddle nose deformity. So this is what that looks like. So you've got this sort of bulging sac of blood. Then rhinitis medicamentosa, as we talked about. And nasal polyps are usually benign, but they may be cancerous. So often if they're quick growing or look a bit funny, it's good to send them off for biopsy. And the treatment is basically oral steroids, and then you give nasal steroids and surgery to get rid of them, because they block up the nose and people snore, etc., etc. Okay, epistaxis, really quick. It's a blood nose. It can either be anterior or posterior. So little kids get anterior and old people get posterior generally, but the large majority are anterior cases. And it's trauma to Little's area or Kisselbach's plexus, which is this. So it's basically just a junction of blood vessels, and it's coincidentally where kids put their fingers, and adults, by the way. Like, yeah, you'd be surprised at the amount of people who come in with blood noses because they've just been digging away. And it's they just get bleeding from one nostril. And then posterior is more up here. So because it's behind the septum, then you get bleeding through both nostrils. Whereas this is already past the septum, so you're bleeding through one nostril. The causes are these. Wouldn't commit that to memory, to be honest. And the treatment is essentially applying pressure just below the bony ridge for 10 minutes. I'm sure you've seen that. Stop them from picking their nose, and then you can use silver nitrate, which are these little sticks, to cauterize the area. And if you think that they have vestibulitis, so inflammation of the area, you can use some mupirocin ointment. And if it's posterior, then you need to do some nasal packing, just to put some sponge up there and just, pack it. Cool. Okay, that's nose. Done. Easy. Neck. I couldn't find a collage of necks, but I got necklines. That's the best I could do. So sore throat, again, the money here is tonsillitis, pharyngitis, and the rest you basically need to know. Yeah, not much about. So pharyngitis and tonsillitis is inflammation of the upper airway. There are different types. So does anyone want to tell me what this is? Maybe if someone wants to do all three, I'll give them a chocolate. Who thinks they know their pharyngitis / tonsillitis is? All right, we'll just do it together. No chocolate, that's fine. So does anyone know what this is? Does anyone tell me what it looks like? Just describe it.
Just a red throat.
Yeah, it's a red throat. So what do you reckon causes a red throat?
Viral.
Yeah, good. A viral infection. So it's increasingly vascular. This is a viral throat. What about this?
Bacteria.
Okay, and what if I showed you this to compare? So which is bacterial? Very good pick, by the way. Yeah, I'll give you a chocolate for that. That's solid. Yeah. That was on you, surely. Okay, so this is bacterial, as you rightly pointed out, and you can see this sort of reticular network of pus on the tonsils. So if that's bacterial, and Cara pointed out that this might be a quinsy, which is definitely something you should look for in bacterial tonsillitis. Does anyone know what a quinsy is? Yeah, good. Peritonsillar abscess. So it just means that the infection is spread into the tissues next to the tonsil, and it can be an emergency because it can obstruct the airway. So this is what then? If that was bacterial, what else gives you tonsils? Anyone? Renee?
EBV.
Yeah. So these are EBV tonsils. So you've got these patches of pus on the tonsils, and this is more characteristic of glandular fever. Okay, so the treatment is that it's usually self-limiting. You give rest, hydration, and analgesia. You can get them to gargle to dissolved aspirin. That works quite well. But you don't give them antibiotics, definitely not, unless their Centaur score is high enough. So essentially, you give antibiotics if you think it's bacterial, because they might have group A strep. And why do we worry about group A strep? Don't say it all at once. Yeah, rheumatic fever, good. So, but again, I'm sure a lot of us, or many people in med would have had a strep throat, but wouldn't have developed rheumatic fever. So even though you might think it's group A strep, some doctors won't even give antibiotics for a strep throat, which is reasonable to some degree. So the Centaur score basically just gives you a likelihood of having group A strep. So if your temperature is over 38, if you have tonsillar exudate, tender anterior cervical lymph nodes, so 3 T's and 2 A's, an absence of cough, and then your age adds up to a point. So that's how you know it would be gas or not. But you definitely have to give antibiotics if they're an Aboriginal and Torres Strait Islander, or if they have persistent disease. So quinsy is a peritonsillar abscess, as we've said, and the signs of that are a deviation of the uvula. So that's how you know that there's swelling in the pharynx. Fetid breath, so bad breath, they can't swallow saliva. Trismus, so not being able to open the mouth because there's sort of inflammation of the muscle spasm. Lateralizing pain, or fullness of the soft palate on the affected side. And it's usually group A strep that causes this, and the treatment is drainage and anti. So this is an emergency because it can obstruct people's airways, which, as you know, is not good. And indications for tonsillectomy are these. So if they have 5 attacks in a year with significant impact on their life, 1 or more episode of quinsy, obstructive sleep apnea, because again, then we're getting into sort of it's affecting their life, and then if it's suspected malignancy, obviously. Okay, so this is about neck lump. I think, yeah.
When would you do a rapid strep test? Like when would
Rapid strep test. Yeah.
when you're not sure enough to give antibiotics, but you think it might be bacterial, so you want to test for it.
What is the? So okay, so I guess if you had pus on the tonsils would be a good indication. And then I guess if you've got a few of these, so if 3 or 4 of these are present, then a 30 to 60% chance of having group A strep. And so if you want to sort of just double check, then I guess you do it. Sorry if that doesn't answer your question particularly. So do you want to go through neck lump? I feel like it's been done to death. but I'll leave the notes up and you guys can go through it. Yes? But essentially, different neck lumps can be different things depending on where they are in the neck. I know this picture looks really awful, but essentially if they're midline, if they're in the anterior or posterior neck, that tells you a lot about what they might be. And this is them. But they can always be lymph nodes because lymph nodes are everywhere. And lymph nodes can essentially be either acute, chronic, or cancerous. And what we worry about is obviously cancer. There are some buzzwords that you should know about though. So when a lymph node is hard in a question, it's usually a secondary carcinoma. If it's rubbery, it's usually lymphoma. And if it's soft, tender, or multiple, then it's probably an infection. Cool. Okay, these are some red flags for cancer. Okay, we're done with ENT. Sad face. I didn't mention Suppurative once. I'm proud. That's my being side, by the way. Okay, so let's go through ophthalm. Do you guys want a break? Okay, want to get home and watch Game of Thrones? It's pretty good. I already watched it. Okay, so the bedside life. Okay, so we're going to go through anatomy, the external eye, anterior eye, posterior eye, and then neuro-ophthalmology, courtesy of Rohit. By the way, this lecture is quite surface. It's not going to get in depth a bit, but if you really want the nitty-gritty of these conditions, I would recommend Rohit's lecture last year. It was very good. Some other ones that are particularly memorable, Karen Freilich's pediatrics cardio lecture, excellent. You learn all of pediatrics cardio without actually knowing any of it. It's really bizarre. It's just all mnemonics, if that's how you learn. And it got me through the exam. So there you go. Okay, so let's go through some anatomy. This is the eye. Welcome. So this is the pupil, the iris. This is the bulbar conjunctiva with the sclera underneath. So the sclera is effectively the white of the eye. This is the limbus, which is the junction of the iris and the cornea and the sclera. This is the medial canthus, lateral canthus, i.e. corner, caruncle. That's probably enough. Yeah. Okay, so this is the upper eyelid anatomy. The things that you should know about are this. So this is the meibomian gland. And that you have some other glands on the underside, and that effectively the conjunctiva lines the inner eyelid and outside of the what's the word I'm looking for? Sclera. Yes. Good. And yeah, these sebaceous glands also come in handy later. This is the eye overall. So does anyone know what the choroid is? Anyone a real keen bean? Cario nodding. Do you know? Now that I've called you a keen bean, you don't answer, but...
Yeah.
Nah, what is it?
I don't really know how to explain it actually.
That's all right. So the choroid is it sits under the retina and effectively supplies, it's an extra blood supply besides from the blood vessels that are already on the retina. Does anyone know what the uvea is? No. Okay, so the uvea simply is everything that's below the sclera. So that involves the choroid, the ciliary body, and the iris. So when you get anterior uveitis, it's inflammation of those layers, right? But the anterior portion, so the ciliary body and the iris. Cool. The lens sits here, then you've got this big sack of jelly, and then the retina's behind, that's what you see. Optic nerve comes out here, and then you've got your fovea later. This is your anterior eye. It's got the lens, and essentially the ciliary body produces aqueous that is sort of travels up around the iris and out here through the canal of Schlemm, through the trabecular meshwork, and then away. This is the retina. Does anyone know which eye this is? You look like you might know. Okay, yeah. So why did you say left?
On the right, where the camera was on.
That one? Yeah, the macula?
The macula is on the right side.
Yeah, so the way that I like to think of it is that between the macula and the optic disc, they sort of form an arrow, and that essentially the optic disc should be nasal, right? So if you think about it, it sort of comes out on those two stalks, and it wouldn't really make sense for it to go that way, so it just comes out straight. That's how I think of it. Okay, do you want to give it to someone else?
Yeah, you just throw it there.
I'll just throw it. That's what I've been doing anyway, but it doesn't seem to be working. Does anyone here want one? Sure, why not? That'll do. Okay. So this is the, I guess, how the retina sees. This is your dispersion of cones and rods. And essentially, you have not that many cones until you get to the fovea, which is the very central part of the macula. And then you have a bunch of cones. So cones see color, see for color, and rods see black and white. And so in the periphery, you've got your black and white vision. And that's why when you're looking at stars, when you look directly, you sort of see more in your peripheral vision because stars are black and white, and they pick up light better. But when you sort of then go to look at them, you then see them with less visual acuity. Okay, we've already done that. Okay, the external eye. So the main things here are blepharitis, chalazion, stye, and cellulitis. I very highly doubt that any of these will be an OSCE station. Then again, maybe blepharitis. Anyway, you guys will see. You can tell me. Okay, so blepharitis is chronic low-grade inflammation of the eyelid margin due to blockage and/or bacterial irritation. The main clinical, so you get basically the red, sandy, irritated eye with sort of a gritty feeling and flaking or crusting. The treatment for pretty much all of these outer eye conditions involves some degree of lid hygiene, which involves some degree of hot compress. So you basically just want to warm everything up and get things going. And then you can basically just put topical lubricants, moisturizers, and you can give them oral doxy for 2 to 3 months if it's particularly severe. Okay, so a chalazion, also known as a meibomian cyst, is blockage of the meibomian gland and buildup of secretions. So you basically get this lump of meibomian gland secretions. So if you guys remember, this is the meibomian gland, and so it blocks off and fills with secretions, and it may be associated with blepharitis because that's how the ducts block up. The symptoms are a painless lump in the eyelid, and the main thing here is a painless lump. So painless lump, upper eyelid, chalazion or / meibomian cyst. And the treatment again, lid hygiene, hot compress, and massage, and manage it basically like blepharitis. And you can also do an incision and curettage if it doesn't go away. Then there's a stye, which is also called a hordeolum. This is an infection of sebaceous glands at the base of the eyelashes with Staph aureus. So clinically, so it's sort of like a furuncle in the ear, but on the eye. Clinically, it's a small pain. So this is a painful bump with a yellow-white tip. It's like an eye pimple. And the treatment is hot compression. Again, surprise, surprise, 3 to 4 times daily, and it may require some sort of antibiotic ointment. Has anyone watched Game of Thrones? I remember. Sorry, spoilers for last season. But I remember this because it's like Hodor is like outside the door, so he's like, this is like outside the eye. And then chalazion, I imagine, is a private Spanish man on the inside of the eye. That's my mind. Okay, so this is just a comparison. Chalazion is inner eyelid, painless, non-infective. Yeah, this is also another way of remembering it because I thought it was too embarrassing, but then I said it anyway. So chalazion, eye on, it's on your eye, it's internal. And then stye is like a pigsty is outside. Pigsties are full of bacteria, are infected. Yes. Okay, so periorbital cellulitis. You've got this, so also known as preseptal cellulitis. This is the septum of the eye. So you basically have this layer of connective tissue that separates the outer eye from the inner eye, so that effectively stuff that is out here doesn't get into here, which sounds like a good idea. And so if you get this infected, it sort of remains in this layer. So generally it's staph or strep, but in children it can be caused by H. influenza, and that's particularly associated with meningitis. And so clinically you'll get fever, erythema, and tenderness, but no proptosis or limitation of ocular movement, because again, it's all localized outside the eye, so none of the good bits are affected. And so this kid has preseptal cellulitis. And the treatment is Fluclox because of staph. Okay, so orbital cellulitis, also known as post-septal cellulitis, is infection usually due to untreated paranasal disease or orbital disease, or some sort of trauma. And clinically, you get a proptosis, painful red eye, and reduced ocular movement and reduced visual acuity. So this is the main differentiator. Because it's inside the eye, you get reduced ocular movement and also reduced visual acuity. In investigations, you should do a CT because sort of once it's past that point, there's a lot that it can go into. And the treatment is ceftriaxone and flu clots because, again, it's more serious, so you want to cover them gram-negative organisms. So this is, again, a comparison table. It's fairly easy, though. So the thing that might happen on the slide, on the exams, that they might give you a picture. And so the picture will look, oh, did I not put in a picture? I swear I did. That's okay. Have you guys all seen the picture? It's like the kid with like the bulging eye. It looks really bad. It looks a lot worse. Maybe Google it. Okay, so then there's something called congenital nasolacrimal duct obstruction. And this is blockage of the nasolacrimal duct due to failure of the membrane to open at birth. So this is a congenital thing. And you basically get a baby with increased tearing, mucopurulent discharge, and reflux of secretions when you sort of press on that nasolacrimal duct. So that's here. Incidentally, the nasolacrimal duct is why your nose gets runny when you cry, as well as other like sympathetic stuff. There's like tears in your nose. And then the treatment is basically probing and antibiotics. Simple enough? Yes, just open the hole and treat the infection. Okay, so the anterior eye. So again, the red stuff is stuff that might come up on the OSCEs. This is conjunctivitis, cataract, and anterior uveitis. And the other ones could all be fair game for questions. I haven't covered these because they're all sort of one-liners in a sense. So anyone have any questions about these if they don't know about them? Cool, sounds good. Okay, so infective conjunctivitis. Viral conjunctivitis is of acute onset and it'll start unilaterally and become bilateral. So now we're talking about the conjunctiva here. So this is the palpebral conjunctiva or the eyelash conjunctiva, and this is the bulbar conjunctiva or the eye conjunctiva. So usually it's adenovirus, and the signs and symptoms of this are a sentinel foreign body sensation. So you sort of think you've got something in the eye before you really have any other symptoms. And then red gritty eyes and chemosis. So that's just basically a bloodshot eye. And then the main things are watery clear discharge as opposed to purulent discharge in bacterial conjunctivitis, preauricular lymphadenopathy, and lymphoid follicles on the eyelids, also known as papillae. So that's these little bumps. And you're contagious for about 2 weeks. It's extremely contagious. So when like kids get this in kindergarten, everyone has it, and it's a bad time. So yeah, the treatment is self-limiting, this time cold compresses, note, and tear supplements, because you basically want to make the eye less angry. Cool? Following so far? Good. So bacterial conjunctivitis is slower onset, and usually, oh no, I've written, no, it's rapid onset. That's a mistake. So this is rapid onset, and it's faster than allergic, sorry. And you essentially have a sentinel foreign body sensation again, but this time you have red sticky eyes with purulent discharge. So that's the main differentiator. And the treatment is topical chloramphenicol drops, and that should pretty much cover it. But you may want to do a culture because you can get some more tricky ones, particularly chlamydia conjunctivitis, which can lead to trachoma. So trachoma is one of the leading causes of blindness in ATSI populations and developing nations. It's a non-sexual sexual infection that occurs with poor sanitation. And the characteristics are particularly, you basically just get scarring and over time inflammation and your eyelashes in turn, and then they can scratch the cornea, which leads to vision loss. And so the treatment for that is 1 gram of azithro orally stat, which is pretty simple, but the main thing is that you should treat people who you think might be carrying it or might have it, and you should also educate the family and the community on the warning signs and good facial hygiene. Cool. All right, so allergic conjunctivitis is a bit of a different beast in the sense that this is an atopic condition caused by, like all atopic conditions. It's like part of hay fever, essentially. And this has extremely itchy eyes. This is more itchy than the other two. And you also get these allergic shiners, which are these dark bags under the eyes, and sort of these glassy eyes because of these watery secretions. But the secretions are probably less than viral conjunctivitis. There's little to no discharge, and it's associated with the nasal symptoms of hay fever. The treatment is olopatadine drops, which is a mast cell stabilizer, or just systemic antihistamines and avoiding the allergens. Cool. So this is a comparison table. Yeah. So the main thing really is the discharge, and then with allergic, it'll just give you other symptoms of like runny nose and itchy eyes, etc. Okay. So foreign body. So this is a condition of the cornea, and the treatment is effectively you just give them anesthetic and then you shove an 18-gauge needle in their face and tell them to hold very still, and you try to take it out with that needle. You then can apply antibiotic drops, And you should definitely refer if it's central cornea, because you don't want to stuff up their central cornea, because that's where they see. If it's in children, because they're not going to sit still. And if it's been present for a long time, it might have become more embedded in the cornea. An intraocular foreign body is more dangerous than a corneal foreign body, because that means it's penetrated through the cornea and is now inside the eye. And the signs are a teardrop pupil. So that essentially means that the iris has been damaged, and the tip of the teardrop will point to where the foreign body is. And this should be referred immediately, because you shouldn't deal with it as a GP. So importantly in GP, everything is from the perspective of a GP. So if you get a intraocular foreign body in your exam and you're like, okay, well, I would, take the patient to theatre and I would put them to sleep and then I would operate on their eye, you wouldn't get points. What you really need to do is to be like, I would, give them symptomatic relief and refer them to an ophthalmologist. That'll be the mark. So just remember, generally in your OSCEs, who you are. So if you're the student, whatever, in a GP, you'll always be the GP. So just keep that in mind. Okay, so chemical exposure, essentially just irrigate. Just flush the eye with a lot of water and refer them to an ophthalmologist again. Okay, so a corneal abrasion is basically a scratch of the cornea, and it's caused by either, it's gone real bad, trauma and a subtarsal foreign body. So that means that there's a foreign body underneath the eyelid, and it's basically just sitting on the eyelid and just scratching the cornea up and down, and that's what's happened here, because you can see these sort of linear scratch patterns. The symptoms are pain and photophobia, and you should examine them with a Woods blue light and fluorescein stain to highlight the defects. So that's what you do here. And if there are linear abrasions, that tells you it's a subtarsal foreign body. The treatment is, again, topical chloramphenicol drops, remove any foreign bodies, and give them oral, not topical analgesia, because that can slow healing. Review them daily until they're healed, but usually it should take about 24 to 48 hours. And complications of this are recurrent corneal erosion syndrome, where effectively it doesn't heal and it just breaks down repeatedly. Cool. Okay, keratitis. So this is basically a group of conditions that are causing inflammation of the cornea itself. So there are a variety of them. So viral, bacterial, fungal, amoebic, parasitic, etc. But the symptoms are, there's sort of a common group of symptoms, which are progressive redness, pain, photophobia, lacrimation, but the main two are sort of pain and photophobia, but that's not particularly specific, because that could really be any number of eye conditions. But they'll give you something extra on the exam. So for instance, herpes simplex keratitis will give you this dendritic ulcer on the cornea, which you can highlight again with fluorescent stain, and that's effectively staining where the herpes has sort of infected by the nerve. And it's often associated with oral herpes. So for this one, for all of these keratitis conditions, you do not give steroids. You'll find out later that this presents quite similarly to some other conditions where you should give steroids. And so the safest thing to do is to refer. Because if you put some steroid drops onto a herpes simplex keratitis, it'll just go nuts. And it'll just go everywhere. Okay, then there's herpes zoster keratitis. So this is when you get infection with sort of shingles of the ophthalmic division of CN5. The symptoms are a red, painful eye. And does anyone know what an associated shingles lesion on the nose is called? Yeah, good, Hutchinson's side. Well done. Do you want a chocolate? I feel like that's fair. Yeah, so essentially you just get shingles all over the... I feel like I'm always one row short. Who knows? Okay. So treatment is essentially refer, don't give them steroids, and then they'll be given a treatment of topical antivirals. Okay, then there's bacterial keratitis. So this is now inflammation of the cornea with a bacterial infection. This is often in contact lens wearers, and that'll be the buzzword in your exam. This is a particularly severe case, and you'll get corneal opacity with an overlying epithelial defect, or ulcer, a conjunctival injection, as well as hypopyon. So hypopyon is just an accumulation of pus behind the cornea. And the treatment is essentially refer, again, don't give steroids, and they'll give topical ciprofloxacin. Okay, then there's anterior uveitis. This is a bit different because now we're talking about infection of the uvea. So as we said, the uvea is the ciliary body, iris, and the choroid together make up that layer, but now we're talking the anterior uvea. So the symptoms of this are essentially a dull pain behind the eye that can radiate, so they'll give you that dull pain. And the other buzzwords for this are limbal flush. So as we said, the limbus is the junction of the cornea and sclera. So that's here. So it's this red ring around the iris as opposed to the blood vessels, as well as posterior synechiae, which is this. This is just the iris sticking and making this strange shape, and it's quite a late sign. Plus minus hypopyon. So really it can present with any one of these, or with any combination of these symptoms. So it's kind of like a burger with the lot, thus that picture, if you're wondering. So if you get one where they have like a lot of symptoms, but the main thing will be like dull pain behind the eye, and if they give you a picture, they'll give you one with limbal flush. So look for that, and that'll be anterior uveitis. But it can also give you sort of mild photophobia, loss of visual acuity, slow onset redness, etc. So this is also called iritis. It's I feel like these slides got backwards. It's inflammation of the anterior uvea, and the causes are either idiopathic or HLA-B27 positive. Does anyone remember what 4 conditions are associated with HLA-B27 positivity? Yes, psoriatic, I heard. Ink bond. What's IBT?
IBD. How much we got?
Yeah, sure. Yeah, that's true. Psoriatic, good. So then there's also reactive arthritis and enteric. Cool. So just a little detour. The treatment here is basically to refer, and here you do give topical steroids. And you can see that some of these symptoms cross over with the symptoms of of conjunctivitis and also of keratitis. So you have to be careful when you give topical steroids to the eye. And so again, referring is the safest option. You can give this drug, which can break down synechiae, but it's sort of beyond scope of GP. And these are the 4 conditions. Cool, so scleritis. So we did anterior uveitis, so we're talking about the uvea. Now we're talking about the sclera, which is this area, right? So the sclera is the white of your eye. And so this is inflammation of the sclera of the eye. It's associated with connective tissue disease. So in 3rd year, you would have constantly rattled off scleritis as a potential symptom of inflammatory diseases. And this is what it is. So it's essentially you get this deep, boring ache, which is very severe. So it's probably, the person will be in a lot of pain and they'll have a very red eye. They'll give you a picture where the eye is diffusely red and inflamed. And that's how you'll differentiate it from some of the other conditions. And the treatment is NSAIDs, and you refer them for steroids. So, yes, the symptoms, no, this should say episcleritis rather. Okay, so episcleritis, on the other hand, is inflammation of the surface of the sclera. And here you get this sort of very mild erythema with just a few vessels, right? So you sort of have moderate ache, red eye in one sector, but not diffusely like in scleritis, so episcleritis, and it's benign and self-limiting. So this one you can leave alone. So you sort of need to pick the difference, because otherwise you'll end up with someone going for steroids and referral, etc., etc. Okay, so this is the difference between the 3. So anterior uveitis, episcleritis, and scleritis. All 3 are sort of treated with steroids except for episcleritis, and they're quite similar. But the main thing I would say differentiates them is the appearance, first of all. So limbal flush in 1, diffuse redness, and then limited redness, as well as the degree of pain. Okay, so cataract, how are we going for time? Okay, 7:20. How is everyone okay? You're not dying? Okay, good. So this is an age/disease-related opacification of the natural lens. So now we're talking about the lens of the eye. And there are different types, but I don't think you need to know about them, to be honest. But essentially, depending on the cause, you can get a different type of opacification of the lens. It's associated with aging, sun exposure, genetics, cigarette smoking, but the big ones are steroid use and diabetes mellitus, as well as age, as well as congenital conditions of Down syndrome. And you'll remember that congenital rubella syndrome gives you cataracts. That's the big buzzword. So clinically, they get a gradual decrease in visual acuity. They sort of get glare and dazzle around bright lights, as well as halos at night, and leukocoria and an opacified lens on examination. So this is essentially what you see, just blurred vision, but slow and over time. And so it's the leading cause of reversible blindness in the world, and the treatment is essentially surgery. So again, refer. With all these questions, particularly with vision loss, a lot of them sort of present somewhat similarly in that the question will tell you that they have vision loss, but the main differentiating factor will be either if it's acute or chronic, and then what kind of visual field defect they have. So if they have chronic diffuse visual field defect where they have blurring, it's likely to be cataracts, particularly if they're like diabetic or old, and you'll see how some of the other conditions present too. So does anyone know what this is? It's just a little side note. Yeah, good. Subconjunctival hemorrhage. So this is like someone's dived to the bottom of the pool and a blood vessel has burst. So this is just, it's harmless essentially. It'll self-resolve. It might sort of bruise over time as it heals, but this isn't dangerous, and it's important to distinguish this from episcleritis and scleritis. So you can see that there's a bleed here as opposed to sort of a network of vessels. Anyone know what this is? This is like a factoid that you'll never see in your life, but comes up on your bio. Yeah, good. Osteogenesis imperfecta gives you blue sclera. Good. Okay. Then, oh yeah, what's this? Okay, so this, I was writing this particular part of the slides at like 12 o'clock or 12:30 at some point, and I went a bit mad. But if someone can answer the next 3 questions, you can have a Kit Kat. But you have to get all 3 of them right. So who's game? So does anyone know what this is for starters? This is the easiest of the 3. Yeah, good. Kaiserfleischer rings. Okay. Next, how's your knowledge of cured meats? Okay, so what's this? You can tell that I wrote this really late at night because I thought this was funny. That's fair. Does anyone know? It's like related to the previous answer. All right, I don't think anyone's going to get this. So Kaiserfleisch is like a type of cured meat. And then, does anyone know what this is? Yeah, this is Kaiser and Fleischer. Good. Okay, you guys can share it maybe if you want. I don't know. Why not? I was like delirious. I'm like, Renee, this is really funny. Okay, so moving on from that. So let's talk about the posterior eye. So they're big complex conditions, and they're worth knowing about, particularly age-related macular degeneration. Diabetic retinopathy could come up in a GP station because it could fit in very well with sort of complex disease management that they like. And also glaucoma is a big one. Yes. So glaucoma isn't really a disease of the posterior eye. It's really a disease of the anterior eye that affects the optic nerve through raising intraocular pressure. So we're not going to cover these 3 conditions because I feel like you cover these ones in 3rd year, and retinitis pigmentosa is just like it's like the osteosclerosis of ophthalm. It's like a genetic condition that results in slow onset blindness in people's 20s, and you get like black bony spicules on ophthalmoscopy. And that's all you need to know about it. Okay, so age-related macular degeneration. This is progressive age-related damage to the macula, leading to loss of central vision. And the most common cause is, it's the most common cause of irreversible vision loss. The risk factors are aging, family history, genetics, hypertension, obesity, and smoking. And you get this, so you get this central scotoma because you get degeneration of the macula, which is your main vision area, right? So basically the center of your vision is eroded. There are 2 types, there's dry and wet. So dry is the chronic stage, and it's characterized by drusen, which are these yellow exudates. So that's here, and they form between the retinal pigmented epithelium and Bruch's membrane, which are, if you remember your retinal histology, which you definitely don't, and that's fine. Essentially, the layers of the retina, you've got the choroid, and then you've got the nerve sensing cells, and you've got this membrane in between, as you get these exudates sitting in between. And essentially, in wet, this is more acute, and it's characterized by scarring and neovascularization. So you get these choroidal blood vessels coming up into the retina to sort of to supply, I guess, the retina, and you get vitreous hemorrhages as a result because these vessels are really unstable and they can just sort of pop and bleed whenever they feel like it. So this sort of is more sudden loss of vision. So the symptoms are progressive asymmetrical vision loss, a central scotoma, and on examination you'll have wavy lines on an Amsler grid which is basically some guy put his name on a grid. And yeah, it just allows you to see how their vision is affected. The treatment is lifestyle modification, so quitting smoking. For dry, there's query evidence about whether or not a high antioxidant diet can work, but otherwise there's not really much. And for wet, you inject anti-VEGF intravitreally. So anti-VEGF essentially stops blood vessel proliferation. It's used a lot in medicine. So anywhere where you want to stop blood vessels from proliferating. So here, for instance, and also in diabetic retinopathy, you can use anti-VEGF therapy. So speak of the devil, diabetic retinopathy is microvascular damage to the retina in diabetic patients. So there are two types. There's non-proliferative, which has these features of hard exudates, dot and blot hemorrhages, microaneurysms, and venous bleeding. These are all like buzzwords. So if you sort of see a few of them in a question, you know that it's diabetic retinopathy. And then there's also proliferative, which is when you have neovascularization, because retinal vessels get damaged and it's compensated for by the choroid, which comes up and tries to sort of resupply whatever's damaged. And you get these hemorrhages as a result. So this is this is non-proliferative, and this is proliferative. So these are your hard exudates. There's a microaneurysm some here. They're like these little dots. Hemorrhages look like hemorrhages. Yes. Okay. Symptoms, they're usually asymptomatic. Otherwise, there's a gradual decline in visual acuity over time, but often diabetic patients won't know that they have diabetic retinopathy. The investigations are that they should see an optometrist every 2 years when they're diagnosed with diabetes, if they don't have any signs of diabetic retinopathy. But if they do have signs of diabetic retinopathy, they need to see their optometrist sooner, so every year or depending on what's relevant. I would highly suggest that you learn your diabetic cycle of care because it comes up. There's like a series of questions where it's like, how often should they get podiatry, and how often should they get their cholesterol done? How often? And also similar things are LFTs for cholesterol, like these like classic like big drugs that GPs give out that need monitoring. So like cholesterol drugs. What's another one? ACE inhibitors and kidney function, perhaps. But definitely the diabetic cycle of care is a good one to know because sometimes it's just like 3 marks, and if you don't know it, you don't know it. It's sort of a shame. So the treatment is better diabetic control. For non-proliferative disease, there's not really much to be done. You basically just monitor them and make sure that their sugars are good. And for proliferative disease, you give laser photocoagulation to stop the blood vessels from proliferating, and anti-VEGF injection again to stop for the same reason. So for hypertensive retinopathy, this is sort of similar disease-ish. So this is retinal damage due to hypertension. Now it's a lot less common because hypertension is obviously better controlled because people are on a lot of I think people are just better aware of it and treating it more. The symptoms is that it's relatively asymptomatic until it's sort of too late. So the types are that there's a chronic and acute stage, and there's 4 grades. So grade 1 is silver wiring, which is essentially atherosclerosis of the arteries in the retina. Grade 2 is previous changes with the exudates and cotton wool spots and silver wiring, as well as AV nicking. So because the arteries are so stiff, when they cross the veins, they sort of compress them, and you see these little compressions of the veins. Grade 3 has flame hemorrhages as well, which are these little hemorrhages. And grade 4 is papilledema. Because of the intense hypertension, you get papilledema. So does anyone know what papilledema is? So it's swelling of the optic disc. It usually indicates raised intracranial pressure. So these are some pictures. So you can see your flame hemorrhages with an eye of faith. Here's AV nicking. So that's pretty clear, right? So you can see that the vein is sort of cut off. Here's a cotton wool spot. Here's a hard exudate. And this shows papilledema. Okay, so the treatment is that there's not really any cure, but you can try some medications. But again, refer. A lot of ophthalmology is refer, except for maybe conjunctivitis and blepharitis and the outer eye conditions, and the stuff that's less dangerous. Okay, so in terms of retinopathies, this is the difference. So between dry age-related macular degeneration, diabetic retinopathy, and then hypertensive retinopathy. And the main thing is really the features on ophthalmoscopy. So let's talk about retinal arteries and retinal veins and what happens when they get blocked. So when the retinal vein gets blocked, essentially all of the blood that comes into the retina backs up into the veins and then it bursts into the retina. So depending on whether or not it's the central retinal vein or a branch of the vein, you get different distributions of hemorrhage. So this is a central retinal vein occlusion, and it's got something called the thunder fundus, which is just this, so hemorrhages everywhere. And this is a branch retinal vein occlusion, which is basically the same thing, but just in a sector. The risk factors are hypertension, age, diabetes, and then the treatment is essentially it's benign, coarse, and self-limiting, but you can give laser photocoagulation or VEGF, again, for CRVO. So on the other hand, branch retinal artery occlusion or complete retinal artery occlusion, central retinal artery occlusion, is more serious. And this is essentially the occlusion of the retinal artery, but because before you were still getting blood to the retina because it was coming through the arteries and then it was spilling out because the veins weren't taking it. In this case, you get ischemia of most of the retina, except for the macula, which is also supplied by the choroid because you've sort of got dual supply. So the symptoms in this one are, again, acute painless monocular vision loss, and the signs are in central retinal artery occlusion, an area of pallor with a cherry red spot. And that's because of the choroidal supply. So this is still getting blood, but the rest of the retina is really not getting much blood. On the other hand, a branch retinal artery occlusion gives you this sort of segment of pallor. So again, they'll basically just give you a fundus on the exam, and you can pick these fairly easily if you know what you're looking for. So the treatment is essentially to drop the intraocular pressure. So you can give mannitol or paracentesis. You want to dislodge the embolus, so massaging the eye and commencing aspirin. And you also want to exclude giant cell arteritis or temporal arteritis because that can cause the blockage of the artery. Yes, obviously you want to refer these ones more than retinal vein, and you probably would refer the retinal vein ones as well. Okay, retinal detachment. This essentially happens to old people. It usually is preceded by vitreous detachment. So vitreous detachment, if you remember that jelly sac that's sitting in the middle of the eye, detaches from the back of the eye, and it can pull the retina with it. So the reason why it detaches is because over time it is less full of jelly and it shrinks. So then it sort of pulls away from the rest of the eye. And so that's preceded by a shower of floaters. So that's the vitreous detachment and flashing lights. And then symptoms of retinal detachment are that you get this dense dark curtain coming down across the vision because that's literally the retina coming off the back of the eye. And you get a sudden loss of vision. The differential diagnosis for flashes and floaters, as an aside, are migraine, as you all know, as well as posterior vitreous detachment. Those are the main ones, but there are a lot. And also physiological floaters. Okay. Risk factors are age, diabetic retinopathy, myopic people. So is myopic long-sighted or short-sighted?
Short-sighted.
Yeah, good. So myopia is short-sighted. And so do short-sighted people have long eyeballs or short eyeballs? Anyone want to answer more definitively? I'm not saying you're wrong. Long eyeballs, good. So because they're long eyeballs, you basically have more risk of the vitreous coming off the eye and detaching from the retina. So the prognosis is essentially vision loss unless it's treated very quickly because it's losing its blood supply, and the treatment is refer. So this is a real emergency. And in the practice, essentially what you can do is you can give them bed rest, reduce their eye movements, fast them, group and hold them, and do an INR because they're basically going in for surgery immediately. Yeah, and these are some of the surgeries that ophthalmologists can do. So a vitrectomy, so they can take out the vitreous, or they can put basically a bubble of air in there to sort of plaster the retina back onto the yeah. So let's talk about glaucoma. So this is a big one. This could easily come up as an OSCE, I feel. Probably open angle glaucoma, or if they want to give you an emergency, closed angle. So open angle glaucoma is a chronic disease. And structural changes to the trabecular network result in reduced drainage and increased ocular pressure. So over 20 is abnormal. And this results in compression of the optic nerve and over time, atrophy of the optic nerve. So often they have normal visual acuity because their central vision is preserved, but their visual field is reduced. So that's the biggest distinction. It's a pretty insidious disease because people don't really know that they have it for a long time. Because of this central sparing. And the signs is that they may have raised intraocular pressure, but not even necessarily. And they may have optic disc cupping, which is the cup to disc ratio. So this is the cup and this is the disc. And when the cup gets bigger because pressure sort of pushes on it and expands it, then you know you have raised intraocular pressure. So risk factors are age, family history, diabetes, thyroid eye disease, and being myopic again, and hypertension. The treatment is essentially to lower the intraocular pressure. So either you can do topical latanoprost or pilocarpine, and timolol is the other big one. So I'd probably say if you had to remember one, it would probably be timolol, and then you can give laser therapy as well. So if I didn't explain properly, it's because the aqueous, which is produced in the ciliary body, can't flow out of the eye fast enough, and you get raised intraocular pressure. Okay, so closed angle glaucoma is the acute condition. So this is essentially where the iris flops over the trabecular meshwork and it just closes off entirely. So you get no drainage at all. And sort of, I guess, funnily enough, it's associated with a better long-term outcome because people are like, hey, what's happening? Because of the symptoms. So the symptoms are acute, painful red eye, radiation to the forehead, decreased visual acuity, a fixed mid-dilated pupil, raised intraocular pressure, and a high cup-to-disc ratio. So it's like buzzword central. They love to ask this question on the exams. And so this, you can see this sort of red eye with a fixed pupil. Yeah, looks pretty angry. Okay, so the risk factors are, they like to tell you that it happens when people are watching TV because essentially they're in dark rooms, and what happens in dark rooms? Your iris dilates, and when it dilates, it's sort of all scrunched up towards the side, and so there's greater chance of it occluding the trabecular meshwork. And apparently if you use antihistamines, it can also increase the chances. Do not dilate the pupil to examine because you will make it worse and you'll raise their intraocular pressure, so that's really bad. If you think that someone has acute glaucoma, refer them to hospital or give them some drops if you have them. But essentially in hospital, they'll just get drop after drop after drop until it gets a little bit better. And then the definitive treatment is a peripheral iridotomy where they basically fire a laser onto the iris to create another outlet for the aqueous to flow into the trabecular meshwork. Cool. If you like lasers, become an ophthalmologist. So this is the difference between open angle and closed angle glaucoma. They're not that similar except in pathophysiology, but one's very acute. Someone will notice it. They'll have a red eye, fixed mid-dilated pupil. Open angle will be a chronic insidious thing, and the main thing to know is that it's peripheral vision loss. Yep. Okay, neuro-ophthalmology. So we'll talk about optic neuritis, and then we'll rapid fire through some questions, and then we're done. And you can all go home and watch Game of Thrones and or Rick and Morty. Okay, so optic neuritis. This is inflammation of the optic nerve, which is often associated with MS and other demyelinating conditions, but not necessarily. So you can just have optic neuritis and it can be fine. Typically, it's in young women, and it results in color vision loss, eye pain that's worse with movement. So painful eye movement and color vision loss is like bang for buck in terms of MCQs. They love to give you those. And signs are normal fundoscopy, as well as a Marcus Gunn pupil and an enlarged blind spot. Does anyone know what a Marcus Gunn pupil is? You see? Yep. Was there anyone here know? I feel like I haven't picked on any of you in a while. Okay, go for it.
So I think it's where you use a swing test and they, hang on, so the afferent doesn't work properly. So when you shine light in one eye, because it's delayed, it constricts with the other eye. Is that correct?
Yes. Okay, so I'll show you an animation and maybe we'll make it clear. So it's a relative afferent pupillary defect. So what does that mean? So essentially what happens in optic neuritis, so optic neuritis is an inflammation of the optic nerve. The optic nerve relays information from the eye to the brain, not from the brain to the eye, right? So it basically tells your brain how much light you're getting. So say it's in one eye, right? Often it's unilateral. So one eye is receiving a lot of light, and one eye is receiving, say, 20% of the light that it normally should be receiving. So when you do your direct responses and your indirect responses individually on the eyes, it looks relatively normal. So you do it to the normal eye constricts, the other eye constricts, and you do it to the affected eye without looking too closely, the eye constricts a bit, the other eye constricts a bit. But it's only when you do the swinging flashlight test that you see that there's a relative pupillary defect. So the eye isn't actually dilating, it's just contracting less, if that makes sense, because the affected eye says, so this eye says, okay, I'm getting 100% of light, and then you swing it to this eye, and it says, okay, I'm getting 20% of light, so it dilates a bit. Does that make sense? But when you do a direct response, it contracts, because it still knows that you're shining more light. Have I confused everyone? Vaguely. I'll explain that. Just remind me. But is everyone else happy? Cool. Okay, so the causes, as I said, MS is associated, but not necessarily. 15% will have MS by 5 years and 50% at 15 years. So it definitely is associated. But there are also some other causes. So these weird bacterial diseases. So investigations usually do a brain and spinal MRI with gadolinium. So that's the classic MS scan. And the treat. Does anyone know what you need to diagnose MS while we're here? Just why not? Yeah, good. But there's like a criteria on a scan. So you need lesions separated in time and space. Good. So you need lesions in different areas of the central nervous system, as well as at different times. So you can't just have a scan and say, okay, well, that person has a lesion today, so they have MS. They have to have lesions at separate times, not the day after another, like, months apart, as well as at different parts of the central nervous system. So that's how you diagnose MS. The treatment is essentially the optic neuritis is benign and self-limiting. You can give them steroids, which hastens their recovery, but there's no long-term benefit. And then you basically should monitor them for any demyelinating conditions in the future. Okay, so Rohit has allowed me to pinch his slides because they're good. And we'll just go rapid fire through these conditions. So can anyone tell me what completely transecting... Okay, actually, you know what? I'll explain ROPD using this diagram. So, okay, so say this eye is affected. Yep. So this eye is receiving 20% of the light, and this eye is receiving 100% of the light. When you shine a light directly into this eye, it says, okay, I had some light, now I have lots of light from the torch, I'm going to constrict. When you shine it into this eye, same thing happens. But it's only when you swing it from 1 to 1 that this eye is getting more light than this eye because the optic nerve is inflamed and not transmitting all the information. So it relatively dilates because it thinks it's getting less light. But when you do direct responses, it constricts what looks like normally. So it's only when you really compare the two that you see that there's a difference. Does that make sense? Okay, so back to this. What would happen if you completely transected one of the optic nerves? What would the pupils do? Just shout it out. Yeah, okay, so they would they dilate, or would they be at rest? Would they be dilated pupils?
At rest.
Okay, so why would they be dilated at rest?
Because it's not getting any light. Like, it's not getting any signals from, like, nothing is going to the brain. So then the brain thinks.
But what about the other eye?
But the other eye's normal.
Yeah.
And this eye is dilated.
Yeah.
Yeah. So then.
So what happens? Okay, so what happens when you shine a bright light into one eye? What happens to the other eye? Constricts. So because this eye is still normal, the brain is still getting light information, and it will control the other pupil with that light information. Because again, pupil control is with CN3. Yeah. So they'll both be the same, and they'll be constricted. Because effectively now your brain is getting all of its light and pupil information from one eye, but still getting it. Does that make sense? Okay. Next case. So this is effectively explaining it. So the consensual light reflex, CN2 goes to the chiasm, et cetera, back to the brain and out through CN3, and both pupils are constricting because it's sending the same information. If you completely transected both optic nerves, okay, now is your time to shine. So what would happen? Yeah, because you're getting no light. So the brain says, okay, there's no light, I'm dilating, I want more light. Good. What about a partial lesion of one of the optic nerves? Anyone else? And what would happen if you shone light on the normal pupil? So onto this pupil. All these questions are based on the same concept. So
in the normal one, the same thing happens with the other one. Constrict equally. Yeah.
that's right. So essentially, the whole concept of this is that your pupil constriction will usually be bilateral if your cranial nerve 3 is normal, and that they'll basically be controlled by whatever most light it's getting out of one pupil. and of one eye, sorry. So cranial nerve 2, regardless of its function, will relay how much light it's getting from both eyes, and the brain will decide how much constriction needs to occur. So in this case, it was saying, okay, I'm getting full light, so we're going to constrict. Yeah. In this case, it was getting no light, so it's going to dilate. And in this case, it's getting what? From the normal eye? Full light, right? So it'll constrict, right? They both constrict normally. So what happens if you shine light in the affected pupil? Yeah, good. So what would happen if you did the swinging test?
It would relatively dilate.
Yeah, good. So you'd have a Marcus Gunn pupil for the same reason, right? So because your CN2 is giving you less light. Goodo. Okay, so a middle-aged obese woman has been suffering from worsening morning headaches for the past 2 months, and this is her retina. What do we see on her retina? Yep. Papilledema, good. And what's papilledema a sign of? Good. So what does she have? Potentially.
Oh, benign intracranial.
Good. So benign intracranial hypertension. Although I think it's not meant to be called benign anymore because it's sort of not benign. But yes. Anyway. So she has raised intracranial pressure, and this is a sign caused by really any papilledema is caused by really any raised intracranial pressure. The clinical features of having papilledema would be visual obscurity essentially and decreased acuity. So you'd have more like the wavy lines, like in RMD. So on fundoscopy, you see these features, and management is essentially just treat the cause. Okay, who can tell me what this is? And there's no light being shown anywhere. It's a cranial nerve defect. So what controls the pupils? You tell me. Do you know which cranial nerve controls pupil size? 3, good. So would you say this is a cranial nerve 3 palsy?
Well, it wasn't kind of what kind of effect was it in the eyes?
Good, good. Okay, so cranial nerve 3 has 2 functions. It's got eye movements and it's got autonomic innervation of the pupil size. Do you remember what the distribution of those fibers might be in the nerve? Good, I'll teach you. Okay, so in this case, no, I was wrong, sorry. He's got a left horner syndrome. So this is a, yeah, no, this is fair, okay. He's got meiosis, ptosis, and anhidrosis. I always find anhidrosis a bit hard to pick from a picture because I feel like it's more of a feel thing. But yes, he does have a, I guess, a ptosis. Vaguely. So is meiosis dilated or constricted? Yeah, good. So where's the horners? It says on the picture, but that's okay. Left, good, right? So this is his ptosis. Maybe. But we will get to a CN3 lesion in a second. So what about this? This is classic. This is like third-year-old, second-year all over again. Good, bitemporal hemianopia. Where's the lesion? Pituitary. Adenoma, leading to compression of? Good. Bang, bang, bang. 100%. Well done. Bitemporal hemianopia, chiasmal lesion from pituitary macroadenoma. What is this? I had a good answer, yeah? Yeah, I feel like you said it.
Right upper longest.
Good, so where's the lesion?
Temporal.
Yes, good. On which side? Good. So left temporal lobe lesion, giving you a right upper quadrantinopia. Okay. What about this?
Macular sparing. Yeah, it's the lesion at the ox.
Which side? Left. Good. So it's a right macular sparing hemianopia. So this is a left occipital lobe lesion. And the reason why you get macular sparing is because you've got dual supply of the macular area of the cortex from PCA and MCA. So if you have a PCA stroke, the MCA is still supplied. Okay, here we go. What is this? The person next to you? So I don't know your name, sorry. What do you reckon it is though? Or can you tell me where it's wrong?
You can't have bottoms of eye on her left side.
Yes, so there's no AB duction. Yep, yep, on the left. So what's the lesion? On? Yeah, good. Cranial nerve 6 palsy. Very good. And you can see here that this eye refuses to AB duct. Yeah, AB abduct. Okay, let's not talk about that. What about this? What about the person next to you? Let's go in a row. So first of all, where's the defect? Sorry? Left cranial nerve. So you think that the defect is here? Okay, so let's take this pain. Where's this eye meant to be looking? In the direction it's going, right? And where's this eye meant to be looking? That way, right? So it can abduct, but it can't go down. I'm not saying you're wrong. So what is it? Yeah? Yeah, good. Okay, so this is, here you can see a dilated pupil of cranial nerve 3 palsy. Sorry, it should be pointing. Oh no, here you can see it. So there's your dilated pupil. And if you see, someone's thumb is actually holding up her eyelid in each of these photos, and here she's got otosis. So this is the cranial nerve 3 palsy, as well as the characteristic defect. So classically, we're taught that you have a down and out pupil. Not so convinced that this is down and out, but you can see based on the eye movements that the only thing that she can do is abduct. But she can't sort of really move this eye. Basically, it's stuck in abduction because the tone of the 6th nerve is holding them. Okay, so this is what I was trying to get at before. So this is important to be able to differentiate between different cranial nerve 3 palsies. So if there is pupil dilation, it means that the outer cranial nerve 3 is affected because the part of the nerve that that has the pupillary fibers are on the periphery of the nerve. So when they're compressed, you get pupil dilation, and that tells you that there is a communicating an aneurysm, which classically is on what branch of? Yeah, so the 3rd nerve, but what artery gives rise to that aneurysm? So it's a pica aneurysm, so posterior communicating PCA, sorry, communicating artery, and it can lead to this little aneurysm, which can then give you this pupil dilation. But if you don't have pupil dilation, it means that really the center of the nerve is affected, and that is usually due to microvascular damage, so things like diabetes. Yeah, if you have the whole nerve wiped, then there's probably some sort of massive aneurysm or some sort of brain condition. Good. So also, as an aside, if you have ptosis and an ipsilateral dilated pupil, so if it's all on the same side, it's a cranial nerve 3 palsy. But if you have ptosis and ipsilateral meiosis, it's a Horner's syndrome. Yes? Everyone happy with that? Okay, so what is this? Do you know? Maybe? Anyone want to shout it out? It's a bit tricky. The picture's not the best. Okay, so let's have a look. Let's look at this eye. So it seems to be moving appropriately in all directions. Let's take a look at this eye. So it's up, side, down, down, side. I guess sort of up, but it's sort of struggling to come up a little bit. So does anyone have any guesses to what might affect this movement? Side and up. Good. So cranial nerve 4 on the left. So these are probably the two pains we can see it the most, and maybe this one as well. Okay, and the real trick to this question is that they give you an MCQ probably that will tell you that they can't read books and they have to tilt their head when they walk downstairs and that kind of thing. And the important thing is that the tilt of the head is away from the affected side, because effectively, say this eye is affected, you're trying to intort it by tilting your head. So you're just making up for that lack of intorsion. Okay, so these are the sort of differentiators. Classically, you know, down and out, this tone, and then inability to AB duct. Okay, what about this? In a child, it's not a palsy. More answers equals more home. Ryan, do you know? Yeah, good. So essentially it's just a form of strabismus. So strabismus comes in many forms, and it can either be esotropic, exotropic, hypermetropic, or hypometropic. And they look like this. So hypertropia and hypertropia are up and down. Exotropia and esotropia are in and out. So you don't know which of these needs, well, these I don't think are that common, but of these two, which one needs treatment? Renee? Exo? So it's ESO. Do you know why it's ESO? Yeah, because they can get amblyopia. And the way that I like to think about it is if the eyes are turned in, their visual field is narrowed. So the development of their vision is stunted. But when they're turned out, they might even have more visual field for all you know, superhumans. No, but effectively their development of the vision isn't affected. And the way that you test whether or not something is really strabismus is something called the Hirschberg test, which is essentially you just look at the right light reflex on the eyes and you see if it's in the same spot on each eye. And the reason why it's important is because, so you can see here that the Hirschberg test is normal, right? So the light reflex is on the same spot on each eye. But if you're doing a real quick examination, you might think that this child has some sort of strabismus. So anyone know what this is called? So pseudostrabismus. So essentially it looks like strabismus, but it isn't. So this is when the eyes appear to be crossed due to a wide nasal bridge, but not really. And it's more common in Asian babies. And yeah, you just look at the light reflex, and if it's normal, then all good. And that doesn't need any treatment. Okay, what about this one? These are like the last few. So you can tell me which is the affected eye. Afdan, do you know?
I'm hoping it's the right eye. Well, that's the left eye period.
Okay, so now I'm getting confused. So the right eye is affected?
Yeah.
As in his right or your right?
It's right.
He's right, yeah. So the right eye is affected. Good. So essentially what is happening here is that he's trying to look towards his left, and the left eye can do that, but the right eye can't. So do you know what's happening here?
No.
And it's not a cranial nerve 6 palsy. What about if we look at this eye? What happens when it goes towards the left? Can we see that there's a bit of nystagmus? Does anyone know what this is? I got yelled at in the second week of third year for not knowing what this was. Thought it was a bit harsh, but that's okay. Yeah, good. So this is intranuclear ophthalmoplegia. Essentially, there's a nucleus in the brain. You can tell that I'm not that good at neuro. That communicates to the eyes that, you know, when you're trying to move the eyes towards one direction, that one eye needs to AB duct and the other eye needs to AD duct, right? So if they're not communicating, then you end up with this picture. So this eye is trying to move to the left. This eye is not really being told to move to the left after a certain point. And so this eye then has nystagmus. It's sort of like trying to send a signal. It's like, come, but it's just not happening. So this is INO. Good. And the lesion is on the same side. If it's unilateral, it's a stroke. If it's bilateral, it's MS. Technically speaking, not necessarily, but for all intents and purposes, sure. Accommodation is usually intact, which is sort of interesting. So if you then went to this guy and said, follow my finger, he'd be able to intern both of his eyes. Because again, that's not that nucleus that's coordinating those movements. Okay, so this is explaining that in more detail. Okay, what about this? So this eyelid kind of looks like someone trying not to fall asleep on a train. It's kind of like, does anyone know what syndrome this is? Or what disease this is, rather? Jason?
Myasthenia gravis.
Good, myasthenia gravis. So he's got this fatigable ptosis. So when he looks up, the eyelid sort of slowly comes down. And then when they put ice on it, it sort of fixes it a little bit. So this is fatigable ptosis, and it's improved on the ice test because it helps to break down the acetylcholinesterase. Yes, so the management for this is pyridostigmine and thymectomy. Sure. Okay, what's this? Everyone should know this. Graves, good. These are the Graves symptoms. You should not get this wrong on your exam. Yeah. And then these are the features of Graves. So you have lid ligand retraction, as well as chemosis and eyelid swelling, as well as the proptosis. Cool, that's it. All right. Anyone have any questions? No? All right, go home. Thank you.